because the adjacent tissue of pterygium is not healthy conjunctiva. A continual autograft is a gold standard. That's a recurrence rate is about 4% to 10%. And however, they have some limitation in case of the patient have a TTD or trapped or glaucoma surgery and pre-existing scar or excessive large or several grafts required. An inferior continual graft is not recommended because it's inadequate tissue for a large graft and afraid of a cinelephalon. This is a video to show that I used the scissor underneath the head of a pterygium that is fast technique and remove all the subconjugal tissue. This is a 2 times video, so it's fast. And after that, we remove the subconjugal tissue at nasal, superior, and inferior. If bleeding is not much, you can use the adrenaline to pat instead of cauterization to avoid the injury of the tissue. After that, you cauterize at the episcleral tissue here with a minimal low cauterization power. Try not to damage the sclera and remove the tissue of the cornea and also use the diamond burr to smooth the cornea. For the donor, we use a superior bulbar conjunctiva cut. You can notice that I not cut until the limbus because afraid of the limbal stem cell at that area. So it's a concept of a conjugal autograft, and this can give the very beautiful cosmetic after the pterygiums. Another tips and tricks is a non-suture techniques. That's in commercial is a tissue glue that contains a fibrinogen and thrombins, and it will be like this in the syringe. And because for the safe cost, we can draw it to many divided syringe as much as you want. In Thailand, some hospitals draw it for 10. That means we can do it for 10 cases. Meta-analysis revealed that fibrin glue versus suture, fibrin glue is significantly reduce the recurrence, reduce the operative time, and reduce the conjugal tissue inflammation, and you don't have to stitch off. If you want to suture, for me, I prefer nylon 10-0 because there's no reaction, but however, you have to cut it about 1 week after that. Try to suture and so stretch the graft as much as possible. And because I try not to have a lot of knot, so I use the running sutures and fix at the capsule of the MR to make it the graft is stretched. For the tissue glue, it's easy and you don't have to suture. Put the syringe 1, syringe 2, and drag the graft to attach at the base thorax, stretch it. And even the patient is not cooperate, you can do it with convenience. And this is a clinical manifestation. The top is a conjugal graft with glue, and the lower part is amniotic graft with glue. So these are tips and tricks for tissue glue, and it's a very useful, especially with the large pterygium, large graft, or recurrence that we have to use a large graft. Another technique is a conjugal rotation of the graft is a 100-degree, the opposite, and we have to remove the subconjugal tissue as that graft and 180 rotation of the graft. However, it's more difficult and prolonged graft hyperemia. This is the result of the studies. Another technique is annular conjugal autograft, and they cut it like this, so it can graft in a large area. And this is the result of that study to show that very nice pictures after that. Another technique is a cultivated contour implantation. As proposed for many years, however, the recurrence is not lower than contour autograft, and it needs a high technologies and high cost, so it's not quite popular. Technique that is claimed that is the lowest recurrence is a contour limbo autograft. However, this is more sophisticated, and because you have to make the superficial correctomy and superficial lamellar dissection to take the donor for the limbal stem cell, and recurrence rate is as low as 1%. So it's a very useful in the case that is many times of a recurrence. And this the case that I did so many years ago, that's a one eye recurrence for more than 10 times. So I decided to use the oral limbo graft here from her daughter, and the rest is an amniotic membrane graft combined with an MHC. The SLED just a report a few years ago, and they claim that the recurrences are low. The techniques is remove the pterygiums and replace the amniotic membrane graft. After that, use the mini SLED in the same eyes, cut it in small pieces, and place on the amniotic membrane. For amniotic membrane graft is very useful, especially when the graft is is very large or bilateral heads, and however the recurrence is still higher than contour graft. So the techniques is use the IPCM art and flat on the surface, and the complete visualization occurs about 1 week. Compared to the contour graft and amniotic membrane graft. Contour graft can give the low risk of recurrence and more beautiful knee. So in this case, it fit for the case that it's a very beautiful girl and needs a high standard recurrence appearance. Or in the fleshy pterygiums or recurrence, you can use it without use adjunctive therapies. For the amniotic membrane graft, we can choose in the case that we need a large graft or bilateral heads. On the case that we can use the donor site. However, the amniotic membrane graft is sometimes if you have to good appearance, you can use adjunctive therapy like MMC. And these are clinical appearance of contour graft and bilateral heads of the amniotic membrane graft. And this is a recurrence that use the amniotic membrane graft combined with MMC. This recurrence, you can see a thick, fleshy pterygium and difficult to remove. You can use the scissor underneath and swipe and remove head. So I try to bit by bit and remove all the subcontour tissue, remove the adhesion, and the bare area is very large, so I use the amniotic membrane graft. Cut it at the area that you want, use it larger, how large, how big, you can decide by yourself. Cut the excess pterygium amniotic membrane. And in this case, again, I use the fibrin glue 1, 2, and stretch the amniotic membrane into that area and cut the excess amniotic membrane and also cut the glue. So amniotic membrane graft, in summary for that, is solve the problems of a large graft, recurrence or the bilateral heads. However, it's not as much as beautiful as contour graft, and we can decide to use MMC to help reduce the recurrence. First of all, adjuvant therapy like MMC if the review they have many since beta radiation, MMC, 5-FU, and anti-VEGF. Now today, I think beta radiation that's used right now, and for MMC is the most popular, is can inhibit fibroblast proliferation in the stroma, can inhibit every cells, and so it can cause the complication like a screw thinning, ulceration, infectious pruritus. So you have to try to avoid that complication. The most common concentration is about 0.02 to 0.04, and RCT show that it's significant to reduce the recurrence of pterygiums. This summaries of that, and titrate the duration of using depends on the pterygium itself. As I mentioned earlier, the grade 1, 2, 3 depends on that. And we can use with the SMART technique. What is the SMART technique? For me, I use a plastic sheet that you already have in the surgical field, cut it in small piece, place underneath between the conjunctiva and scleras to protect the scleras, and use an MMC, the soap in sponge, so MMC is not directly contact to the sclera. Rinse the normoxidil for me is about 100 cc. This is appearance, 1 month and 5 months. In this case, what do you do with this case? Is a recurrence for, I think, about 3 times and have a synaphyllon. You can notice that. And it should be used a large graft. But amniotic membrane may be not enough to prevent the recurrence, so I decided to remove it and use the conjugal graft combined with the amniotic membrane. And conjugal graft, notice that it cut until the limbus. So I will have some limbal stem cell. This is a video to show that. It's a very thick and fibrous tissue. Try to remove it. The head first, preserve the conjugal tissue because we will push it back to the fornix, cut in a very small piece of the conjunctiva, only at the scar, at the margin area. This, you can see, cut it is very small, remove the same techniques that we use in the pterygium excision. And after that, we take the donor, check the MR, restrictions, is okay, still we will not cut it, and cut the fibrosis around that area, remove it all, and place the MMC with the SMART technique that I explained. After that, take the donor at the superior part, and you can see that I cut all along to the limbus. And you see here, make it thin, flat, and cut until the limbus. Take some part of the limbus. That is not much. So the donor area is still okay. Try to stretch the limbal half to at the limbal area of the cornea at the same site. Use the fibrin glue to that. In this kind of case, fibrin glue is very useful because otherwise it's very difficult to suture. After we place the conjugal graft and we place the amniotic membrane, can push it underneath to the fornix. Make its fornix is as deep as possible and stretch the whole graft, check for restrictions, and place the contact lens. And this is the result of 1 month, and after that it's still okay for a year or maybe more. How's about the 5-FU? It's inhibit the S phase of the cell cycle, so it's not inhibit every cell. It's directly inhibit the proliferative cell that is corneal can see them. So the complication may be PED or encephalopathy when you use it. This is a studies from my study for many years. Is an RCT and show that compare the control triamcinolone and 5-FU intralesional injection, and the study showed that 5-FU is the best and can reduce the recurrence. If you remember this type, I use this type to inhibit because that type may be a recurrence, and the study showed that 5-FU is the winner. Like this, we use the injected syringe insulin about 0.1 cc, inject directly at the intralesional lesions, as maybe separates of 1 to 2 weeks apart. How many times depend on the appearance of the tissue, maybe 2 times or 4 times, and prevent the leakage when you inject, because otherwise the corneal repeater maybe have the problems, and rinse the normal saline afterward. Inject in the case that it only at 6 months, not more than that, because 6 months the fibroblast will become a mature fibroblast, and we cannot prevent it. Anti-VEGF, also the same techniques, and the studies show that it can reduce the recurrence rate, also the same. And for conclusion, pterygium is a common disease in tropic countries. It seems to be simple, but it's not. The aim of surgery not only